All right, thanks for the introduction, Mark. Yeah, as he mentioned, this is actually a follow-up work to some of the simulation studies that we demonstrated earlier this year at the UITC meeting, where we're trying to basically validate this technique that we call ASH to measure bleeding. The clinical background, a little bit, percutaneous coronary intervention is a minimally invasive procedure where a catheter is inserted through the femoral artery to access the coronary arteries and do some kind of intervention. It turns out that many of these patients are on anticoagulant therapy, so when the catheter is removed, bleeding can be a big problem because they're not able to reach hemostasis as sort of a normal patient. And then one of the tricky things is that about 41% of post-PCI bleeding is subclinical. So a nurse just visually inspecting the catheter insertion site can't determine whether the patient has reached hemostasis. So currently there's no really non-invasive imaging methods to determine when a patient has reached hemostasis and clotted when the catheter is removed. So to address this need, our lab has developed this technique that we call ARFI-Surveillance of subcutaneous hemorrhage, or ASH. So the picture on the left here shows our typical ASH setup. We have our ultrasound transducer positioned above the point of catheter insertion and removal. And essentially we perform ARFI imaging after the catheter is removed. And we've shown in preclinical and clinical studies that we can actually measure time to hemostasis. So this data set was from one of our clinical studies where we showed significant reduction in time to hemostasis with patients that had a hemostatic dressing versus controls that just had manual compression alone. So how does ASH work? ASH works essentially by measuring jitter in displacement profiles. So on an ARFI data set, we get our typical displacement versus time curve. And what we do in ASH is we look at the last 2 milliseconds of this time curve, take the second derivative of displacement to get acceleration, and then we take the variance of that in order to get an idea of the jitter. What we've seen in our studies is that regions of hemorrhage tend to have higher variance of acceleration, or VOA values, than areas of soft tissue. So we can threshold based on the jitter, and areas of high jitter we can say are going to be hemorrhage, areas of low jitter are going to be sort of non-hemorrhage pixels. So this sort of led us to the question, what system parameters will influence VOA? For that, we looked to the Kramer-Rao lower bound, which was derived for ultrasonic estimators. This is the equation, which basically showed that there are 5 main parameters that are important for jitter, and they're all inversely proportional. So center frequency, bandwidth, kernel size, signal-to-noise ratio, and correlation coefficient. As any of these are increased, VOA, we would predict, would decrease. So for the purpose of this study, we're going to focus on kernel size, SNR, and correlation coefficient, keeping the other 2 parameters constant. The overall hypothesis, of course, is that by adjusting system parameters, we can optimize hemorrhagic blood detection by increasing the difference in VOA between soft tissue and blood. So to test this hypothesis, we developed a hybrid simulation framework based on the LS-DYNA FEM-based package that was developed at Duke by Mark Palmieri and his colleagues. So essentially what we do is we use LS-DYNA to simulate ARFI-induced motion. We can then pipe that ARFI-induced motion into field 2 to give us an idea of what the ultrasound representation of that motion would look like. And to sort of do our ASH simulation, we inject a very simple blood scatter model where here we can sort of manipulate the amount of decorrelation that happens in the signal. And I'll talk about this in the next slides. From field 2, we can get our RF data. From the RF data, we can add white noise to simulate SNR. We obviously have to motion track, so here we can manipulate our motion tracking parameters. We calculate VOA from our motion profiles, and we can get our simulated ASH result. So how do we sort of simulate these untethered, extravasated blood scatters? So this is a movie that's showing the ultrasound transducer and a zoomed-in version of the scatters that we are inputting into our field simulation. So in a perfect case, when we excite with radiation force, we're going to have displacement away from the transducer and perfect recovery back to 0 if nothing moves. So the scatters will be perfectly correlated from time point 1 to the time point end. So what we did in order to simulate sort of these loose blood scatters that aren't necessarily elastically tethered to the muscle tissue that they're in, we added some positional uncertainty in the recovery. So I've represented these scatters as having smaller diameters, but they're actually not. They have lower backscatter coefficients to represent the lower backscatter of blood. Using this type of simulation, we can range the concentration of these sort of positional uncertainty scatterers. We can change the amount of uncertainty from 1 to 5 microns in this case. And in this case, we kept the backscatter amplitude to about 1/10 of the surrounding scatters, or negative 20 dB. But that's something that we can manipulate in the future using this framework. So just quickly to go through the FEM methods, we utilized LS-DYNA. Stiffness of our mesh was about 25 kPa in a viscoelastic material. We simulated a 4 megahertz ARFI pulse, and then our tracking was centered at 6 megahertz. We ranged our SNR from 5 to 50 dB, sort of spanning a poor ultrasound system to a very, very good ultrasound system. We ranged our kernel size from 1.5 lambda to 10 lambda, and repeated this experiment with 30 scatter realizations. Additionally, we implemented sort of a 2-dimensional version where we simulated a growing hemorrhage. So to do this, we sort of designated these hemispherical regions that grow over time. They not only grow in space, but they grow in concentration of these untethered scatters. So this is kind of the idea that, you know, the area nearest the puncture site is going to have the most amount of blood, and then it's going to sort of diffuse and through the surrounding tissue. And then we simulated also 2 time steps after that to represent hemostasis, or when this hemorrhage has stopped growing. From the 2-dimensional data set, we can do an ROC analysis where we manipulate our VOA threshold to get an idea of our performance. So jumping into the results here, I'm going to first show you results comparing our simulation to some experimental data from our preclinical dog studies. So here we have an experimental displacement versus time curve in a region of known hemorrhage. We see that we have our displacement, and then we have some jitter happening at the end. We take the second derivative to get acceleration. We look at the last 2 milliseconds, and we get a VOA value of about 0.065. In our simulation, if we compare that to a 1.5 lambda, 40 dB, 30% scatters, and plus or minus 5 micron, we get a very similar curve. Perhaps not as much displacement in our simulation, but the noise levels seem particularly similar. If we take the acceleration and look at the last 2 milliseconds, we get a VOA of about 0.069. So we get relatively close. We think that this simulation is sort of representing what's, what the kind of data that we get in our in vivo sims, or in vivo data. Okay, so now this result is showing the variance of acceleration values in a log scale as a function of SNR. So this black line is showing a baseline case where no hemorrhagic scatters were added to the simulation. As expected, we have a decreasing, it's exponentially decreasing, because this is a log scale, decrease of VOA with SNR. As we add in our hemorrhagic scatters, we see an interesting effect. So at low values of SNR, we really don't have that much difference between VOA from soft tissue, or our baseline case, and our hemorrhagic simulations. But as we get into the lower end, the higher SNRs, we see that we start to get separation. And if we look at the 5 micron case, we see even more separation, as expected, because the 5 micron is going to have more sort of decorrelation, and it's going to increase the jitter and VOA. So to sort of quantify all of this into one plot for all the different simulations that we ran, what we're showing here is a log compressed p-value. So now we're doing a t-test comparing our hemorrhage simulation to baseline as a function of SNR. So anything that falls below the dashed line here is going to be a p-value statistically significant 0.05 alpha level. As expected, in our low SNR sims, none of our parameters actually reach statistical significance, suggesting that we would not be able to detect blood in this case. As we go into the 20 to 30 dB range, we start to see sort of this waterfall cascade happening with the filled markers falling under the line. And the filled, of course, is the 5 micron simulation case. So as expected, we can use a lower, a somewhat low SNR, but still be able to detect these scatters that are moving with this kind of motion profile. As we continue to increase SNR, now we start to see that the open markers fall below the line, suggesting that even the 1 micron cases are differentiable from soft tissue. If we look at the 2D results, this is a plot of AUC versus the 6 time steps. As expected, the lowest time step, which has the lowest concentration and smallest area, is going to have a relatively poor AUC, and this is for a 1.5 lambda kernel. As we increase our time step and increase concentration of scatterers, we start to do a little better job to differentiate. Interestingly, if we increase our kernel size, we see that the AUC actually increases. So this suggests that using an increased kernel size actually can do a better job of separating these two distributions. So that was for the 1 micron case. If we compare that to the 5 micron case, we saw that we had very good discrimination, almost AUCs above 0.95. So it was a very kind of easy case, I guess, for our method. Okay, so the AUC essentially tells us performance, but how does that relate to actually detecting blood area and sort of understanding bleeding dynamics? So in ASH, essentially we want to measure the time at which hemostasis is reached and some of the dynamics in terms of the slope, how fast somebody's bleeding, et cetera. So here what I'm showing is detected blood area versus time for a given VOA threshold that we optimized using the ROC analysis. And this is for a 5 lambda kernel. Here are the actual images that we get, and we can see that we do a relatively good job picking out both the slope and this time to plateau. If we look at the data in aggregate, what we notice is that in the 1 micron case, we get very poor estimation with the small kernel size. If we go up into the 7 and 10 lambda kernels, a pretty large kernel sizes, we start to do a little better job. With the 5 micron case, though, we're doing a very nice job of representing the actual bleeding dynamics in this case. So to conclude, these simulations have been very instructive. We've demonstrated that for sufficiently high levels of SNR, around 20 dB, ASH can statistically distinguish these regions of hemorrhage as a function of both concentration motion and concentration of scatterers and scatter motion. If we optimize kernel size, we may actually be able to improve our separability of hemorrhage from background. And the results suggest that ASH may be implemented to distinguish pixels corresponding to hemorrhage. Of course, at this point, we don't really understand what's happening. Why is VOA increasing as a result of hemorrhage? So these simulations can serve as a nice framework to test various hypotheses for us. And with that, I'd like to conclude and thank all our collaborators, and I'll be happy to take any questions.